So thank you very much for having me here. So I knew I'll be coming late. Most of it are probably I'm exhausted all the hacks. So I'm coming out with a very simple hack. Basically, last 2 years I have been only doing hydrodelineation in all my cases, so that only hydrodissection, no hydrodelineation. And also I rotate it, not like netto rosately, but I'm rotating things little more and more, elaborately than otherwise normally I would do, which probably has reduced my, cortex aspiration time greatly. And also by not having an epinucleus with all its attendance problems, I think having just a bulky single nucleus without a epinucleus would be definitely a great game changer. And the second thing is my use of sharp chopper has increased tremendously in the last 2 years. I was doing stop and chop for most of the softer cataracts and little dense cataracts also, unless it was a very hard cataract. But now I have found we can, with an experience, we can actually, and using the same chopper all the time, you can actually try to chop most of the cases, unless it is very soft. And this sharp chopper will definitely be more zonule friendly, and also it will definitely fragment the nucleus much faster than you trying to make a trench, divide them and create all the zonal stress. So this has been my learning last 2 years, and it has really benefited me greatly. And the other three are not related to basically surgical steps. One is about use of medication. After a lot of deliberation and getting influences from others, now my steroids are only 4 times for 1 week, and Nepavans or Nepafenac is once for 4 weeks. In most of my cases, which are straightforward, uneventful cases and the things they follow. So this has greatly reduced the inconvenience and the quality of life for the patients, where they have a lot of problems putting the drops. And of late, I have not found much of a patient coming with any flare-up of reaction or any other problems. And this has really worked for most. If there's a problem, uneventful case, or requires a lot of post-op medication, then I'll change this accordingly. And this is SAVE. SAVE is acronym for self-assessment of vision every day. This chart we prepared for some other program, and now I've been handing this chart. It is used for, there is an instruction at the back, how to use this at 4 meters, and the patient from day 2 is taught by the counselors how to use the chart. It is like a standard chart at 4 meters, you keep reading it. And if the patient has a drop in the vision, most of the topical phagoes will see well, despite the minor refractive errors. If there is a drop in the vision, then the patient can keep on assessing. So we give it to patients, especially who are far off, so they can really know when to actually come back. And this has really worked a lot in some cases. And the last one is about, in select cases where I'm doing monovision, I can always call them for a glass prescription 1 or 2 weeks, but I prescribe a +2 right on day 1 of my second eye of the surgery, so that I have found that because patients can't wait to see clearly for 1 or 2 weeks, even that is actually difficult, so this can be a definite plus point if you just give a plus reader, which is very simple, very economical, and giving them a glasses right from day 1 on the second eye. They can actually be very happy from day 1 to read or look into their mobile, and there will be actually an enhancement of their patient satisfaction. Thank you very much. Save? You're saving yourself from...
Save, I mean, I didn't get the idea of...
Save is, this was a chart, we have basically, reduced the number, made our own chart, which is to be used for...
No, why did you start thinking about something like that?
It started like, basically, you are ophthalmologist. The only thing, most of the problems come out with the patient basically manifests or comes up with a vision loss. And this vision, estimation need not be done by an optometrist or ophthalmologist. It can, anybody with a chart can do it. It is like giving the patient and empowering the public to check their own vision.
No,
if there's a problem...
This is not post-op.
Not post-op, no.
Post-op.
Post-op.
Immediate post-op.
Immediate post-op to check. It is not 6'6". This is a chart which is modified to be used at 10 feet.
You give 6'12", they'll be happy reading last line.
No, this is not a 6'6" vision chart. It is to be used at 10 feet. It is basically for comparison. It is not for absolute measurement. From today what you saw, from tomorrow it should be the same or it should get better. It should not drop. So the instructions are very clear. We are saying if you don't read the last line, it's okay.
I'm not convinced. I'm not. See, you go to the Ayurveda people, they actually say, okay, with the Ayurveda treatment, vision has improved. They keep taking the patient.
No.
So why should?
No. I will explain the rationale. There are a lot of postgraduates here. See, whenever you introduce microorganisms into the eye, till they get into the vitreous, there is no drop in the vision. Vitreous involvement by microorganisms is the turning point, which will drastically reduce the vision. Okay, that can happen on say, day 2, day 3, day 4, never know. So when the patient, most of our cataract post-op, you can see that they get good vision to at least see 10 feet. It is not that they have to read the whole chart. They are seeing the 2 lines at 10 feet on day 1. Second day it should be same, if not better. But if it drops, they're not able to see the chart. So this is an objective way. You can just say, see, drop in the vision without any actual measurement. It's a very, very qualitative. Old people may not really know. And there may not be anybody can have. Vision is, whether they're seeing or not, is a very qualitative thing. This is a semi-quantitative thing, which actually has worked. We have been using it for the last 10 years.
I've been taught well.
And it has actually saved us from people that are reporting early. Our post-op patients with the problems have been reporting early because of this.
Okay. Like we said, in Malayalam here, idoru kodali avu ennu samshayam undennu.
Kodali
You
means,
didn't
okay.
understand.
Anyway, the thing is,
No. I think this axe is very, very blunt.
sir, again about the post-op medication. 1 week antibiotic steroid combination. 1 week.
1 week.
4 times a day for 1 week. And then,
stop.
and then 1 month, once a day.
Nepafenac. So this was little revolutionary, but we kind of started pilots and we have found, and this is not for 100% of patients. This goes to around 80% of my patients, and it has worked well. And it has drastically reduced the ocular surface problems, obviously, and the patient's quality of life.
So this 80% you choose or
I choose.
You choose. Okay.
I choose.
Okay.
I choose the patients.
Then
Not
patients don't have a problem. See, there are patients who are sitting
So
together.
patients who are very bad diabetics, where there is a tissue handling, or there is some kind of, where you use iris hooks. So basically where there has been a tissue handling, it is not a very quick surgery, not a quick surgery, then obviously you need to step up the steroid a little more. We have a different, but it's not for 4 weeks of steroids. We quickly taper it in 2-3 weeks only. But Nepafenac, we try to use it twice. Rather than
And
once.
one problem we face is that a few patients come and sit close to each other, when post-op 3rd day and all those, they will keep talking. And they will say, I have been given drop only for 1 week. You are for how many weeks? I am for 1 month. 1 month. Why should you use 1 month? Then something is wrong. I have been told wrong. You had same surgery? Then it is trouble explaining to them is what I have realized. And that is a practical problem which we face in our clinic.
Yeah, maybe that's something that can happen, yes. So maybe our post-ops patient don't sit together.